And retrospectively, this study has been looked at, the Women's Health Initiative study, and it's clear that we can't really apply it in the modern day.
Hi there, and welcome to Am I Crazy Or? The podcast where I, Lisa Påske, take on all the ways that society is trying to gaslight us into thinking we are going crazy. This season, we are tackling the perimenopause. They often call it the second spring. I think it's more like the monsoon season. But I'm not doing this on my own. Each episode, I'll be interviewing a variety of experts as well as women going through it. In this episode, we will be talking again to Dr. Mayura Mahadevan, a menopause specialist doctor with the Menopause Care Clinic here in the UK. In this episode, we will be covering everything HRT, Hormone Replacement Therapy. Dr. Mayura will be going through all the different options that are available to you, the side effects, and any other information that you need to know. Hello again.
Hello.
I'm so glad to have you on the second part of this podcast. And today I want to talk to you about HRT and actually getting onto HRT. Mm-hmm. So for anyone that didn't listen to the other episode, please do go and listen to that about the symptoms and all about it. So Mayura, you're a menopause specialist.
Yes, that's right. So I'm a menopause specialist and GP. I work out of a clinic in Wimbledon called Menopause Care, and I work with a team of other menopause specialist doctors. And I'm a GP also in Wimbledon.
Cool. So, yes, we talked about this in the other episode of how I came to you about a year ago now. So I'm just a year into my journey, and how I finally came to you and then started HRT literally October last year. So there are so many things that I realized, there are a lot of talk about menopause and symptoms and, what symptoms and diagnosis and so on. But what I have realized is there's a whole nother journey, and that is to get the right combination of the hormones for you.
Exactly. Yes, it's tricky sometimes, and sometimes it's very straightforward. But we do very often have a bit of a journey where we are trialing different types and doses of HRT to find the right combination for each person.
First of all, what is HRT, and what kind of medications is that included in? Like what?
So HRT stands for Hormone Replacement Therapy, and that's what it's widely known as in the UK. In other parts of the world, it might be called MHT, Menopausal Hormone Therapy. But basically, it's a way of topping up and getting the right levels of the various hormones that are depleting in the perimenopause and menopause. So the main ones we're talking about here are estrogen and progesterone, but testosterone will also come into that.
Cool. I would like to maybe spend some time talking about why HRT has such a bad rep. When I first started looking into it, I had a lot of people saying that they decided not to go on HRT because they heard that they believed that it could potentially give you cancer. Do you know where did that start? What is that?
So we have to look at the sort of history of using HRT as part of women's healthcare, and it goes back quite a long time. So HRT became increasingly popular in the late 1960s and early 70s, and initially it was just estrogen treatment. And then later on, it was realised that progesterone was also needed. And so from then onwards, actually, quite large numbers of women were being prescribed HRT with really excellent results. And then a study was started, the WHI study, the Women's Health Initiative study, was started in the late 1990s. And it was the first really big study that was looking at the effectiveness and safety of HRT. And it was a longitudinal study, so it was done over a number of years. And the study, part of the study was stopped I think it was in 2002, because some of the results were suggesting that HRT was dangerous and was bringing about an increase in cardiovascular disease, so heart attacks and strokes, and also increase in breast cancer. So, of course, the study was stopped. And unfortunately, at that time, the results were passed on to the world's media. And so it was a huge media campaign that really cast this massive shadow over HRT for patients and for doctors. So, prescribing came to, almost an abrupt halt at the time. And retrospectively, this study has been looked at, and it's clear that we can't really apply it to what we're doing and in the management of the menopause in the modern day. So it was a huge study, as I said, with many thousands of women included in it. And it was divided into two arms, actually. So there was one arm of women who had a uterus, who were treated with an estrogen and a progesterone. And then the other arm was with women who didn't have a uterus, who had a hysterectomy or were born without a uterus, and they were treated only with estrogen. And it was the estrogen and progesterone arm of the study that was stopped. And when we look back at that study, we need to bear in mind that actually the hormones used at that time were conjugated equine estrogen and a synthetic progesterone in oral form. So nowhere was body identical transdermal type of hormone used, which is what we aim to use in the modern day. And the other thing to mention about this study was the women included in the study, I think, had an average age of over 60.
What?
So the vast majority of them were more than 10 years past their menopause, and large numbers of them had comorbidities, which means that they might have had diabetes or pre-existing cardiovascular disease. So all of these things really need to be taken into account. But interestingly, one of the things that people don't talk about is the fact that although these results showed an increase in cardiovascular disease and breast cancer, it actually showed a decrease in mortality associated with osteoporosis and bowel cancer.
Wow.
So, and nobody talks about that. And the other arm, which continued, the estrogen-only arm, which was still using oral synthetic estrogen, the longer-term results were quite encouraging. It seemed that there was no increased risk of breast cancer in that arm of estrogen only. So when we look at this study now, we realise that if we're using natural hormones that are given through the skin to women, the younger women who are perimenopause or within 10 years of stopping their periods, then HRT can be very safe for a number of those women. But I think it's also important when we're talking about starting HRT is to ensure that our women are given the right lifestyle advice as well. I know you had done an awful lot before coming to see me, and a lot of my patients have. They've looked at exercise and their diet to make sure they've got enough protein and fibre in their diet. Looking at trying to manage stress and getting sleep right. Trying to do as much holistically as possible alongside trying to manage these hormonal fluctuations with HRT.
Yeah, it's so interesting how that one study derailed treatment for women for so long.
Totally. And I think the results were published in the national press. And it was at a time when I was a fairly newly qualified GP. So I was that generation of doctors who suddenly decided not to prescribe because,
Right.
these were quite damning results.
Yeah, of course. And that's the thing, is like looking at the data now and how that's why press is so can be so helpful, but also so damaging for progress in medicine, and also studies and stuff. They can, like, you really need to know what is looking at, and not just the conclusions I get.
Exactly.
But yes, so you mentioned there, which I think is really interesting. And when I first came to see you, I had like very little knowledge about the types of medication. So can you explain to me what it means, body identical and transdermal?
Yes, of course. So body identical hormones are basically those which have the same chemical structure as what we are producing naturally in our ovaries. So if we're looking at the type of estrogen and the progesterone, actually these products that we use, they are regulated pharmaceutical products, so they've gone through the rigorous testing processes and so on. But they actually derive their hormones from yams, interestingly.
Oh.
So there's a vegetable source to the hormones. And when we take those, because they have they're body identical, they're very well tolerated. So they're not generally going to cause huge problems that some of the synthetic hormonal preparations do. And transdermal simply means through the skin.
Okay.
And when we use estrogen transdermally, it avoids first pass through the liver, which is a way that drugs are metabolized. So transdermally, the product gets straight into our bloodstream, circulates, and has its effect. If we take something orally, it then goes through our gut, through our hepatic system into the liver, where clotting factors can be activated. And that's why some hormonal products can increase the risk of blood clot. For example, the oral contraceptive pill, the combined oral contraceptive pill. So women who take that need to have a yearly checkup, which includes a blood pressure check. That is because these medicines can increase the risk of blood clot, and we need to establish that the person taking this medication doesn't already have high blood pressure, which would also increase the risk of blood clot and then perhaps result in a deep vein thrombosis, which can be very dangerous.
Okay. And so by taking hormones transdermally, the risk of clotting is none or disappear?
Well, I would say it's pretty much none. I don't think we've got definitive data to say that, but the risk is minute, and we would regard it as a zero risk if you're using it's estrogen actually that can be taken transdermally. At the moment, we don't have a body identical progesterone product that can be used transdermally, but it's the estrogen that we use transdermally now.
Taking estrogen transdermally, does it change? Does some women absorb more or less? Does your skin change? Like, does that matter?
Yes. So this is the issue with transdermal estrogen products. So the item will have a particular dose. For example, a patch will have a particular dose, and we would apply that, and we would hope that would have a particular effect to improve symptoms. Now, there are various doses. Now, why do we have those? Well, it's because of absorption. So not every person will absorb every transdermal product the same. So there are some women who absorb well via the patch, but not so well via the gel, and vice versa. And I can't tell by looking at you which one is going to suit. So that's why very often we have a discussion and a journey to get the right treatment.
Okay, so let's take estrogen first. What are the options for estrogen when you start HRT?
So if we're talking about body identical estrogen, transdermally at present in the UK, we have patches which give a sort of sustained release. So for most women, this would be a patch that's used twice a week. So for example, you put it on a Monday, and then on a Thursday you would take it off and put a new one on. So it's a slow release over 3 to 4 days. Then we've got daily application preparations, and the two main ones are gels, and there is also a spray product as well. But in addition to that, you can get body identical oral estrogen.
Okay.
So for some women who, for whatever reason, preference might mean they don't want a transdermal product, or it may be that they've tried transdermal products and they, really don't absorb at all using any of them, then we do have body identical estrogen as well. And to be honest with you, they're widely used and they're very convenient. And in a woman who is healthy and low risk with no other risk factors for clot, on discussion, this may be the right treatment for them.
Yeah. So I went with the spray, because I didn't really fancy the gel. I think what a lot of women that I now talk to, they're using the gel. They are there for half an hour in the morning, touching themselves, rubbing their thighs.
Yes.
But it seems like there's not a lot of people that are using the spray. Is that not often prescribed by GPs or?
I'm not sure. I think I think the gel, particularly estrogel, is a product that's been around. It's been well marketed, and I think very well accepted and tolerated by women, and therefore I think it's very often the first go-to. But you're right. If you're using numbers of pumps of the gel, if your symptoms mean that you need 3 pumps or 4 pumps, there's a lot of rubbing in of gel on different body parts, and you need a few more minutes in the morning perhaps to allow it to dry, and then get dressed, whereas the spray can be considered quicker.
Super quick. I like it, dries very quickly, but you have to be very careful, right, for not touching anything.
You do have to be cautious about this, and it's important to allow it to absorb and then get dressed and not cuddle children and pets and so on.
Yes. Yeah. So that's for estrogen. It is mostly the spray, the gel, the patches. A lot of my friends are on patches, to be fair. But I have very sensitive skin, so anything it just gets itchy, like plasters even get. In terms of progesterone, what are the options with progesterone, and how is that absorbed? And
so the vast majority of progesterone products are oral. You've got progesterone, the natural progesterone, micronized progesterone, and then there are a number of synthetic progestogens, and a lot of those are taken orally. But there is, for example, there's one patch preparation which contains body identical estrogen plus a synthetic progestogen, which is very convenient, and lots of women use that product, but it isn't body identical. And the other thing about that particular product is you can't adjust the dose. It's in one fixed dose. So it's brilliant if you try it and it works well for you, fantastic. But if you need dose adjustments, it's not so useful. But another very useful way of getting progesterone into the system is the Mirena coil. There are other products, but that's the most widely used one. And that's where a progestogen is released directly into the area in which it's needed. So it's directly into the womb to protect the womb lining. And the good thing about this product is, particularly for the perimenopausal younger woman, it offers really robust endometrial protection, and it's useful for women who've experienced heavy periods because it can control bleeding, and it's also a method of contraception, and it's your progesterone component of HRT for 5 years after fitting. So you've got the Mirena coil, you've got your patch, and that's it, you're done.
Yeah. Why isn't there a transdermal progesterone?
I don't know the answer to that. I think it must be something to do with the molecule
Okay.
and the pharmacokinetics of the product. But yes, we don't have a transdermal body identical progesterone product at the moment.
And is there any risk? So for the patches that is transdermal progestin, is it?
Yes.
Progestin.
Yes.
Is there any side effects with that, or any risk with that not being body identical?
So I think really that the main risk is the very small increased risk of breast cancer,
Okay.
which is associated much more with the synthetic progestogens.
Yeah.
The body identical micronized progesterone seems to be extremely low risk, or there are some studies which have suggested it's breast cancer neutral for at least 5 years of use.
Okay. So one of the things that I'm quite keen to talk about, because it's quite relevant to me, is that progesterone intolerance. So I when I first came to see you, we talked about a lot of my kind of medical history and stuff, and I'd never been on the birth control pill. Well, I had tried it in my late 20s, but got admitted to hospital with 80% of my body in rash. And I was told that I had a reaction to the, because I was on the combined pill, so it was progesterone and I never really thought anything of it. I just knew that I couldn't take the pill. So I had to think of other ways of birth control. But now when I started thinking about going on HRT, I was really worried because obviously I'd had that reaction. And when I first started taking the progesterone, I think it's utrogestin I take by mouth, so actually orally, I had such bad side effects. I felt really low and really angry very quickly. Also had rash mostly on my neck, like round little patches. And that I realized is probably progesterone intolerance.
Yes, I think we decided it was, didn't we? And it's interesting. So there are women who don't tolerate progestogens as well, particularly in your case, you noticed it earlier on, and interestingly, that sometimes ties into women who have PMS and postnatal depression as well. But there are ways around this when it comes to HRT. They tend to be off-label uses of products, and it's important to do this type of tweaking of HRT under the guidance of a specialist, I would say. But yes, so for example, the utrogestin product, which is usually taken orally, and that's how it's licensed to be used. In some cases, it's appropriate to be used vaginally. The progesterone component of HRT is mainly for the purpose of protecting the womb lining and keeping it thin and healthy in the presence of the extra estrogen we're giving as part of HRT. So if you think about it, it can be used as a sort of local preparation. But as I said, this is a sort of complex area of menopause management, and a lot of other factors do need to be taken into account before we advise on different routes of administration.
Because I realized that for me, so I did go down that route and take it vaginally, and I have had no severe side effects or anything. Like, it made a huge difference to me. and I realized that this is a very much like an off-label way of taking it. I'm quite curious about if you take progesterone vaginally, does it also help? Because progesterone has different kind of impact on your body. Does this still help you, like they always say that progesterone will help you sleep better or like make you calmer, although I never really did that for me. It made me crazy.
Yes, so a lot of women find that it's very calming and sleep inducing, and so that's really when it's systemic, so when you take it orally. So the systemic absorption when it's used vaginally is much lower.
Yeah, because then it just goes on there. So it's mostly then for making sure that the lining of the womb is
exactly
shedded.
Yeah.
So progesterone is also important to take as part of your HRT. Why is it so important to also take progesterone?
So for women who have a womb, the endometrium, which is the womb lining, can thicken under the influence of estrogen. And in a normal menstrual cycle, that's exactly what happens. So in the natural menstrual cycle of a woman in 20s and 30s, we have a cycle of estrogen and progesterone, which varies through the month. And that cycling of the two hormones is what brings on the thickening of the womb lining, which then is shed, and that's what a period is. In menopause management, we're topping up estrogen to improve current symptoms of the menopause. But in doing so, that can bring about a thickening of the womb lining. And if we don't use a progesterone at the same time, in theory, you could end up with problematic thickening of the womb lining, and in more extreme cases, endometrial cancer. So this is why it's so important that women who have a womb are given appropriate doses and levels of estrogen alongside an appropriate level of progesterone.
I also keen to talk to you about progesterone and PMS, or the hormones in general and PMS, because this seems to be like it got a lot worse for me, for sure, and I know that's the same for a lot of women. What is the combination? What happens during the PMS period?
Yeah. So it's to do with hormonal fluctuations, and it very often happens in the phase of the menstrual cycle just leading up to the period. So that's the luteal phase, when progesterone level is increasing and the estrogen level is decreasing. So it appears that there's more progesterone during those days or weeks, and that's very often when the symptoms of mood disturbance and other physical symptoms can come on. So it's very often in that phase. And when those symptoms become very troublesome and require treatment, in a younger woman, often a doctor will prescribe something like the contraceptive pill, the combined oral contraceptive pill. And what that does is give a flat level of hormone throughout the month. So it eliminates the fluctuating cycle. And for a lot of women, that works really well. In the perimenopause, we can start by trying to top up with some estrogen to even out that cycling of hormones.
Because I feel like I might just be very sensitive to maybe that's more the term. I'm progesterone sensitive.
Yeah.
So any kind of like increase of progesterone seemed to send me up the bend and go crazy.
Yeah.
And it's like, but is it usually is it a progesterone increase that makes that anger thing? Because that's the thing that I really kind of feel like in my teenage years and after having kids, and now in perimenopause, the whole like the rage that suddenly comes on. Is that or is it just the change?
It's difficult to say because, of course, when progesterone levels are high, the estrogen levels are low, and whether it's that difference, the combination of the two. And then, of course, you've got life stuff going on around you as well. So it's very difficult to know the exact answer to that.
I used to have this thing when I was a CEO and I ran this agency. I was so aware of my PMS and how it affected others, because you could, like, I can't keep energy in, like you can really see it on my face. So I used to have this like Darth Vader stress ball that I would put on my desk. That would literally be like warning everyone, you can come into this room, but you might want to wait till next week. So they were like, oh no, Darth Vader's there, we're not going in. What about women that have had a hysterectomy? What HRT do they take?
So a woman who's had a hysterectomy, in theory, doesn't need a progesterone to protect her womb lining, because there is no womb lining. So for many women with a hysterectomy, when they have HRT, it's straightforward estrogen only HRT. Now I have to kind of qualify that a little, because it depends a lot on the reasons for the hysterectomy. So for example, if a woman has had a history of endometriosis, depending on the hysterectomy and the extent of the endometriosis, she is quite likely to require some progesterone. But largely, a woman with a hysterectomy doesn't require progesterone and can take estrogen only. But again, that's something that needs to be discussed with a specialist.
Okay, so one of the things that I have talked to a lot of my friends about is when they started HRT and so on. I'd be interested to know, is there ideal time to start HRT? And also, is there a time where it's too late?
So ideally, HRT is best started younger. So it's very safe when started in the perimenopause. And in any case, ideally, we try and start it within 10 years of the menopause. So there's what we call a window of opportunity in which it's a good idea to start HRT. Now, that doesn't mean if a woman aged 60 approached me with symptoms, it doesn't mean that she couldn't have HRT. It's very individual, and a lot then depends on a discussion about her medical history, her general state of health, and her particular symptoms. But ideally, in the perimenopause, in the younger woman, and within 10 years of stopping periods.
Okay, so because I think this is one of the kind of myths. Certainly, like most of my friends around, I'm 46 now, and so I started at 45. But certainly my friends back in Norway, they were like, oh no, I'm not going to start that and like that. I'm not in menopause yet. Mm. But that's really confusing. So I could have started in my 40s, like actually 40 when I started having symptoms, but I didn't know. Would that have been the best time, or is it just as long as it is before?
I think the main thing is to look at an individual's symptoms, and if the symptoms are bad enough for you to seek advice, then obviously that's an indication that that's a good time to start treatment. And you know, as we've discussed previously, the purpose of HRT is to help you feel better now, but also we've got this added benefit of the longer term health improvements that we know exist. So we know that women who are taking HRT have got lower future risks associated with osteoporosis and cardiovascular disease and dementia and diabetes. You know, these are all big issues as women get older. So the fact that the HRT serves both purposes is very, very positive.
Yeah, and that's a really good point actually of how much how important HRT is for conditions later in life. Like now, having done so much research, I realized just how important it is to have enough have the right hormone level to be able to be stronger, for your bones not to be fragile. Like the amount of people, like of my friends, their mother who's broken leg,
yes,
like hip replacements and so on. Is that estrogen particularly that helps the bone?
It is, yes. So that's why osteoporosis and thinning of the bones is a condition that occurs largely in women after the menopause when their estrogen levels have dropped. Obviously, in some women it starts earlier, but the vast majority it's postmenopausally. And HRT basically stops that declining bone strength.
Yeah.
So as long as a woman is taking HRT, she's being protected against osteoporosis.
Amazing. And also heart disease and all of this, where I for one would like to try to be healthy and strong as long as possible. So the last hormone we haven't talked about is testosterone. And so how important is testosterone for women, and what does testosterone impact?
So it's an important female hormone, and when we're younger, we have quite a lot of it, and it declines as we get older. Testosterone as part of HRT, so if we're thinking about prescribing testosterone to a woman, according to NICE guidance, the indication is for low libido that hasn't improved with HRT, estrogen progesterone HRT. But alongside that, we need to look at the general improvements that we see, and there's an awful lot of data now, and you have to remember that the research doesn't exist, it hasn't been done, which is why we can't evidence this. But I know that research is now being done in large menopause clinics across the world. But there seems to be evidence of improvement in higher mental functioning, so memory, focus, but also energy levels, mood, muscle strength. So it covers sort of a broad area, but if we're being very strict about licensing, it's really for the treatment of low libido.
Interesting. So basically, when it affects the man, we will get. Then they're like, "Yeah, give us some testosterone." Yeah, that is very interesting. Because I've been reading about testosterone and especially the impact on muscles and stuff. And that's obviously again really important to keep strong and healthy and agile throughout getting older. So yeah, it's very frustrating that is so hard to get. Like I understand that the NHS doesn't prescribe it at all.
So in the NHS, largely for testosterone to be prescribed, it would normally be through a specialist menopause clinic. But having said that, there are some GPs who do prescribe it. They tend to be the GPs who have an interest in the menopause and maybe have done some additional training. But largely in the UK, you would have to be seen by a menopause specialist, either in the NHS or in the private sector, in order to be prescribed testosterone.
Yeah, because I feel like, and then the last thing with that, I think, so I have a couple of friends that are on testosterone as well. The testosterone is a cream, a gel format, or what is they usually taken as?
So that's another interesting thing about the testosterone products. So in the UK, we only generally have male testosterone products, which interestingly, we call them male products because they're formulated for men and they're packaged in doses for a man. For example, there's one product where a single sachet is a single dose for a man, but of course that would be too much for a woman. So if a woman was prescribed that product, they would have to use a part of that sachet, and usually it's about an eighth. So one sachet, it's a very small sachet, has to be eked out over about 8 days. But interestingly, it's the same testosterone molecule that's in all products, and it's also body identical, so it's from the yam. And that product, the one I've told you about in the sachet, is a gel. There is a female testosterone product which is manufactured and licensed for menopausal women, and it's from Australia. So that's in a cream, actually, an almond oil cream, and that's only available privately in the UK. But I believe that there are discussions underway for that product to be made available on the NHS.
Oh, that would be amazing, because I really feel like after a year now on HRT, I feel like a different person. For one, for me, the first 6 months of taking HRT was like coming back to life, and actually becoming actually feeling like myself again. And I did more work in those 6 months, or actually, I think from January this year, the first 6 months of this year, I got more stuff done than the 3 years before that put together.
Wow.
And that's how declined I was cognitively in. But the thing that still kind of lingers a bit is is the Dory brain, as I call it. I still struggle to remember, like the short-term memory, and I'm definitely not as sharp and as quick as I used to be. So it would be great if testosterone is really considered for women in a different way. But that's the other, the last thing I think would be fun to talk about is just how little research has been done for women in childbearing age and in menopause.
Yes.
We're kind of like forgotten.
I think the funding isn't available, or hasn't been in the past. I think things are changing now. So funding is now coming forward, and as I said, there are lots of large menopause clinics, establishments where research is underway, and hopefully in the next few years we'll have the results of a lot of this research, because of course research takes time. You need lots of patient data, you need time to look at results and so on. So hopefully things will change in the future. And of course the other thing to mention about, you saying that your brain's not quite there and so on, is in the perimenopause we're really working with a moving target, aren't we? Because your internal hormones are still declining. And so that's why there's a lot of tweaking of treatment that's required, because where you were a year ago, your actual hormone levels overall might have been higher, probably were higher than they are today. Yeah. And therefore doses do need to be adjusted.
Yeah, that's interesting. And so how long do you think it generally takes to get to the right place with HRT?
So that's very, very variable.
Yeah.
For some women, it happens very quickly. For others, it takes some time. You can then have a period of stability and then require some tweaks and changes, particularly in the perimenopause. So, for example, yourself, you started HRT quite early on in your perimenopause journey. So it's likely that there are some changes, small adjustments that are needed as we go forward. But generally, once you are menopausal and you then are really just getting your hormones through the HRT, hopefully we would reach a fairly steady state at some point.
Yeah, that is what I'm hoping for. I'll be stable. I think that would surprise everyone. Okay, so there isn't really any kind of exact time, but I think maybe the main thing that I have learned is that it will take some time to get it right. So being patient with it, because I feel like a lot of people might try it for a bit and then feel like it didn't help enough, or they might feel worse and therefore stop, which I think is a big shame.
Yeah, I think it's difficult when you're not feeling well. This is the thing, and you're really hoping for quick changes, and it happens sometimes and other times it doesn't. I think it's important to realise also that when starting hormonal preparations, you can have a period of adjustment. So some women do experience a bit of headache or a bit of breast tenderness, changes in bleeding pattern. And these changes are usually transient. The bleeding changes can go on for a few months, but will usually settle down within a few months. And hopefully all will be well. I think it's important also to mention that any woman who has, prolonged or very heavy bleeding, which is out of character, if that happens when they're taking HRT, it's really important to report that to a doctor to make sure everything is in order.
Yeah. For me, the main side effect when I started taking estrogen was just very tender breasts, and that continued for a couple of months. But now I don't have that at all. So a lot of the side effects does kind of calm down, I guess.
Yes.
Is there any advice that you can give to women that are wanting to try HRT in terms of the period of testing? Is there anything else they should be doing?
Well, I think it's important to address all the elements that you can as soon as possible. So lifestyle and sleep and stress and diet, exercise, all of these things are going to help. I think we spoke, didn't we, probably early on when we were discussing this, about making sure you don't have too much alcohol in your diet, looking at caffeine, just it's general healthy living advice. But that's so important, because sometimes you get distracted from that side of things, don't you, when you're not feeling well, when you're having perimenopausal symptoms. Yeah. But I think having done those things, documenting and keeping a record of what's going on with you with particular symptoms, and then just being really open and having a discussion with your GP about whether this could be the perimenopause and whether a trial of treatment is appropriate. The other thing is talk to your friends, talk to people about it, because sometimes airing it really does make a difference.
Yes, I totally agree. And as soon as you start talking about it, you realize that way many, yes. I didn't realize that half the people that I now know are on HRT were on HRT because yes. they kept it quiet. Yeah. And so just talking about it really helps everyone feeling comfortable about saying, oh, I might actually go and see someone and try it out.
Well, it's true, because if you think about it, slightly more than half the population is going to be affected by this. They are going to go through the menopause. There's no way of getting away from it.
Yeah.
And not everybody will struggle or have symptoms that need a specific treatment, but everyone will go through it, so everyone will have their own experience.
Yeah. I heard somewhere that by 2030, it will be 1.3 billion women in active menopause.
Wow.
Or in perimenopause.
Well, if you think about it, if a woman starts perimenopause early, in mid to late 30s, and then a postmenopausal, we've got, longer lifespans now. So from mid 30s to mid 80s plus,
yeah,
that's a huge amount of women across the world.
Exactly, and it's time that we get some help. Oh, thank you so much again. You have been a delight to chat to, and thank you for everything that you've done for me and for everyone else. Thank you.
You're very welcome. Thank you.
Thank you. Hello again. I hope you enjoyed that conversation. Isn't Dr. Mayura amazing? You can see why I felt so safe in her hands. She has taught me so much, and I'm sure she taught you a few things as well. If you have any questions, please leave them below or send us a message on Instagram. I would also really love to hear any suggestions to topics that you want me to cover. Lastly, it would mean a lot to me if you follow the podcast and leave us a 5-star review. Thank you so much for listening to Am I Crazy? Or see you next time. Questions echo in my mind, searching answers can't seem to find. Is it me or something more? Is the dragon